All right, let's get started. First of all, thank you very much for coming and joining us. This is the new normal, these Zoom meetings, and as many as I've done, I'm still a little inept at the whole technological thing. So bear with me if we get some hiccups. My name is Ken Rauschenbach. I've been an orthopedic surgeon here in the Newburgh area for about 22 years. I work for Orthopedic Associates of Dutchess County, and I'm based out of New Windsor. I've been doing hip and knee replacement for those 22 years, and we're going to talk about arthritis, specifically hip and knee replacement, and then some talk about the ROSA robot, which is a robotic assistant that helps us improve our alignment and position of our prosthetic components. So arthritis, what is it? Arthritis is, wear and tear of our joints. The problem with it is we all get it, it's inevitable. And the most typical one is called osteoarthritis. That's the wear and tear. There are other forms, including rheumatoid arthritis, which you've heard about, some of the inflammatory arthropathies, but what we're talking about tonight is the classic osteoarthritis that everyone's mom and dad and eventually you will have. To the severity, it differs, but everyone gets it. What do we do about it, and what are our options? Arthritis is joint inflammation. It worsens with age. Symptoms include swelling, pain, immobility, difficulty doing activities of daily living. You become tired quicker because it wears on the body. Can really limit our activities and what we can do in life. And when it gets to that point, then we're talking about something surgical. But before we get there, what do? Treatment options. The most important thing is understanding that we're all going to get this at some point, okay? And what can we do to prevent it or minimize it? The first step would be, activity modification when it starts to act up. We can, weight loss is super important, increasing our activities to strengthen the muscles around our joints will take the pressure off them. If that alone isn't enough, we take a stepwise approach. Medications. Medications can include over-the-counter rubs, as well as Tylenol and the anti-inflammatory medicines, which are the mainstay of treatment. Those include the Advils, the Aleve, or some of the prescribed medications you'll get from your doctor. If the medicine and the non-surgical stuff doesn't work, steroid injections, okay? This is the first step in two types of injections we can use. The idea of the steroid is to reduce the inflammation, which is your pain generator in arthritis. Arthritis is wear and tear, and the smooth, perfectly aligned joints become a little rough and almost like two pieces of sandpaper coming together. This causes an inflammatory response, and that inflammation is what causes the pain. If we can use medication, i.e. anti-inflammatory medication and or the steroids to reduce that inflammation, we can give symptom relief. Again, it doesn't cure the arthritis or fix it. The next type of injection we can use are called the gel or viscosupplementation injections. You guys have heard of the rooster comb and the different variants. These are an excellent alternative. They don't work on everybody. The idea being it's going to bathe the articular surface in the nutrients it needs and prevent further degeneration. There's nothing out there that, creates new cartilage or fixes the arthritis, okay? Bracing, unloader braces, things that can take the pressure off the joint. Again, all of these things are buying us time until ultimately none of our conservative options work, and then we're looking at a surgical option, okay? Arthroscopy. Arthroscopy was something we used back in, 20 years ago to scrape the arthritis. Some of the older gentlemen I see say, can you go in there and just scrape it? We know that doesn't really work, and it's pretty much been abandoned for arthritis. Alternative treatments, you've heard of the stem cells. This is a very hot topic. Unfortunately, none of them are covered by insurance. They're very expensive, and their efficacy is, in great doubt. Very little downside to it except the expense. But as of this point, it is not mainstream medicine. It's an alternative. Someday that might be a great option. We just haven't gotten there in our science yet to make that a go-to. And ultimately, when all of these things don't work, then we're looking at joint replacement surgery. The two things we're going to talk about today are the hip and the knee. These are the most common joint replacements. Well over 600,000 joint replacements are done in America per year at this point, with a slightly more knee than hip. The arthritic condition is painful. You can see on these x-rays on the normal hip, there's a space between that ball and socket joint. The abnormal hip, it's that darker white and it's completely obliterated, meaning the cartilage that makes up that area has been worn away. Typical pain you get is deep in the groin, thigh, and even in the knee sometimes is a referred pain. It causes limitation of motion, difficulty ambulating, and even sleeping at night. Hip anatomy is as above. It's a ball and socket joint. It's got that white shiny surface. Imagine popping a chicken bone open and you see in that knuckle, it's smooth and even and shiny. If you took a hammer to that and became uneven and then tried to do the same motion, it would catch and grind. And that's essentially what's going on in an arthritic hip. Hip replacement surgery. What we're doing is we're realigning that, resurfacing that joint. So we're taking that uneven catching irregular surface and we're replacing it with a metal socket, a metal stem, and then the bearing surface is typically made out of ceramic on the ball side and a polyethylene or plastic on the other side. So you can see the horrible arthritis on that left side and then the hip replacement on the right. One of the newer techniques that I perform here at St. Luke's is the anterior approach. It's been around a long time. Typically about 50% of all hip replacements in America are done posteriorly. The anterior approach allows us to do a muscle sparing approach where we can kind of move between the muscles rather than have to detach them and reattach them. The advantage being that a slightly shorter recovery time. The hospital stay is about the same, possibly even a half a day shorter, and they get up a little moving and recovery is a little bit faster. And, 6 weeks, everything's essentially the same, but that first few days are a little bit better through that anterior approach. The downside being, it's a very limited approach, and big muscle men, heavier people, it's a more difficult approach and usually is not attempted. So when are you ready for a hip replacement? Okay, the only reason to do a hip replacement is pain. People say, I can't move as fast as I was. I can't play basketball anymore. My skiing career is kind of over. That's not a reason. This is for pain. This is when you get to the point where, hey, I can't do my activities of daily living. I can't walk through the supermarket without having significant pain, having to sit down and rest. That's when you make that determination. You make that determination with your orthopedic surgeon, and most likely have exhausted most of those conservative options that we spoke about earlier. Knee arthritis, similar to the hip, again, it's wear and tear of that articular cartilage, causing this irregular surface and malalignment. You see the one on the left, the normal knee, with two even spaces, that's filled with the cartilage. You can't see that on an x-ray. On the opposite side, you see that red area where that bone is essentially touching the bone. You get that painful grinding, catching sensation. Most arthritis is gradual onset. It gets worse and worse over time. But occasionally you get that sharp, something happens, and all of a sudden the straw that broke the camel's back type scenario, and it progresses quite rapidly. It causes stiffness, limited range of motion, buckling, catching, and again, chronic, achy, toothache-like pain. Again, that smooth, shiny surface is the articular cartilage. You see those wound-shaped cartilages, those are the meniscus, which you've heard about, and then those wear out over time along with the cartilage. Knee replacement surgery, same as the hip. We're going in there and we're essentially giving you a new bearing surface. We take away that articular surface and we realign it with these metal components. And what fills the gap now where the cartilage and the meniscus were is this plastic component that sits in the middle that gives you a nice smooth bearing. We tension the ligaments, we align it better, so you're not in that big bow-legged or knock-knee position, and it gives us the best chance at longevity. Neither hip or knee replacement lasts forever. Typically, we're talking about knees going from anywhere from 15 to 20 years and hips going from 20 to 25. That's a good amount of time, but when you have the unfortunate need for a knee or a hip replacement when you're in your 50s, you need to get it redone again. What we've come up with is options to make our cuts more precise because we understand that the better the alignment, the better the position, the more chance of that knee or hip lasting a long, long time. So we've come up with these robotically assisted procedures. We're doing them for knee replacement now and hip replacement in the future. The idea is to get the best possible alignment and cuts that you can in order to provide the best possible longevity for that knee replacement, okay? It's kind of a misconception that, I'm sitting in another room and that robot's doing the surgery for me. That's not how this particular robot works. It's an assisted procedure. I essentially make every single cut myself. I do all the surgery myself. The only thing the robot's doing is helping me align the blocks that I make the cut through to get the best possible position, the most balanced, even knee replacement. So hopefully it will improve our longevity. This is the setup in the operating room. So we have this big boom camera that comes in, and on the knee replacement, we essentially put these arrays, one above and one below. We take pictures and we map out the joint. So we have essentially a real-time picture of our knee in front of us on the screen. We're then able to adjust the positions and have a preoperative plan that we can make the most perfect alignment possible before we even get started. The idea is that that can be adjusted on the fly so that if we don't like anything, it's easily adjustable. But so far, it's been very reliable. In the past, we'd have to make multiple cuts, change our positions. We use these jigs, and it worked very well, don't get me wrong. But hopefully this will improve our accuracy, improve the longevity of the total knee, and make for a longer lasting implant. Procedure takes 30 to 60 minutes of tourniquet time. The nice part nowadays with our opioid sparing approaches, we're minimizing pain medication so that you can get up and get moving right away. We use special injections, and essentially we're getting people up usually in about 2 hours post-operatively. Most people are staying in the hospital less than 2 days. I see it's on the slide, it says 2 to 3 days. I can't remember the last time a patient had to stay that third day, to be honest with you. We get you up right away, aggressive physical therapy, aggressive range of motion exercises. We get you back to your normal life. Typically, it takes about 4 to 6 weeks to be back to most normal activities, depending on your comorbidities, all these different things, they kind of play a role. Sedentary jobs, I have people back at 2 weeks. More advanced, construction workers, more like 4 to 6 weeks, and then more advanced activity, including, light level sports, usually about 3 to 4 months. So the key points, arthritis is here to stay. We're all getting it. Our population is getting older, and people want to be more active. They want to be involved in sports and activities and do things. They don't want to retire and sit on the couch. So using these procedures, we can really make that last a long, long time and at a minimal pain, and we can continue to improve things. Hopefully this ROSA robot that we've been using will improve our cuts, improve our position, and hopefully in turn, improve our longevity of the joint replacement.